Hi, my name is Angelina Viola, and I'm going to be presenting on nutritional support during hospitalization among cancer patients. So a little overview of what this presentation is going to look at. We're going to address the problem presented to us in our paper. We're going to talk about the intervention and how everything works, how they fit it all together. We're going to go into the results. We're going to look at the discussion and conclusion in the paper, and then the future outlooks of this study. So the problem, it's the nutritional risk of hospitalized cancer patients. So malnutrition affects about 30% of oncological and hematological malignancy patients. This results in higher mortality, impaired functional status, and longer hospital stays. The clinical presentation of malnutrition in patients with cancer usually causes a loss of weight and appetite, a loss of muscle mass with sarcopenia, and severe tumor cachexia. Some reasons for risk are tumor-derived cytokine release, which can severely decrease appetite, sometimes resulting in anorexia. The side effects of cancer treatments can also severely decrease appetite or even prevent you from ingesting food at all. Like a lot of times, throwing up is very common in many cancer treatments. So you obviously wouldn't want to eat very much. Fasting, excessive fasting for diagnostic studies, and sorry, it's cut off at the bottom here, but it says suboptimal nutritional management. So the goal of our study is to investigate the effects of nutritional support during hospital stay versus usual care hospital food on mortality and other clinical outcomes. So to do this, our study compares an individualized nutritional support intervention group versus a standard hospital food control group at a mortality regarding the mortality at a 30-day primary endpoint and other clinical outcomes, which we'll discuss in the paper. Okay, so getting into the intervention, what did this look like? So all participating centers had an active malnutrition screening in place. Basically, the way this works is this score is a very well-established tool to assess malnutrition risk based on the patient's nutritional status and the disease severity. And the score ranges from 0 to 7 points. So a score of 3 or higher indicates an increased nutritional risk. So the patients used in this study only had a score of 3 or higher, so they were all at nutritional risk, and they had an expected length of a hospital stay of greater than 4 days. And the main admission reason to the hospital was the diagnosis of cancer. So eventually 506 patients were 506 patients were chosen for this study and then assigned into 2 equal groups, the intervention group, which had nutritional support, and then the control group with no nutritional support. So how did this work? The nutritional support group received support by a registered dietitian to reach certain protein and energy goals, and the energy requirements were predicted using the weight-adjusted Harris-Benedict equation, which is shown below, here for women and here for men. And this equation should look very familiar because we just used it in our case study. And then the control group had just standard hospital food and was served on the ability and desire to eat. And they had no nutritional consultation or recommendation for any type of nutritional support at all. Okay. Okay, so obviously different patients have different needs based on the severity of their disease, the type of cancer, and many other factors. So with the dietitian, they would determine these needs. And then for acute disease, there would be higher protein breakdown, where the daily protein intake was set at 1.2 to 1.4 grams per kilograms body weight. And then for lower protein breakdown for patients with renal failure specifically, protein intake was set lower at 0.8 grams to kilograms for body weight. And the plan initially was just based on oral nutrition by the hospital kitchen, including food adjustments according to the patient preferences, food fortification such as enrichment with protein powders, and providing patients with in-between meals and snacks, in between meals, snacks, and occasionally they would offer nutritional supplements if the dietitian thought that it was necessary. So, however, if the patient could not meet 75% of their energy and protein targets within 5 days, further nutritional support was actually provided through tube feeding. So I thought that was an interesting adjustment they made to the study. So the nutritional intake was reassessed every 24 to 48 hours, and then upon discharge, there was dietary counseling and prescriptions for oral nutritional supplementation if indicated. So after discharge, there was no contact between the nutritionist and the patient. It was just this right before discharge. They had this like final rundown of how they could upkeep their health after they were hospitalized. Okay, so going into the results of our study, at the 30-day follow-up, the control group had 50 patients, or 19.9%, which had died. And then the intervention group had 36, or 14.1%, that had died. So for the 6-month follow-up, the control group had 128 deaths, or 52.7%, and the intervention group had 115 deaths, or 47.3%. There was also compared to the intervention group, there was a way higher risk in the control group for functional decline in activities in daily life. And the patients receiving nutritional support showed significant improvements of the quality of life. There was no significant differences found in the secondary outcomes, such as length of hospital stay and non-elective hospital readmission. Okay, moving into our discussion. So nutritional risk is strongly associated with the mortality at 6 months. And then compared to the control group, the nutritional intervention group had significant improvement in mortality and functional outcomes in the short term. And this was consistent among many different types of cancers and the predefined subgroups. And then further on to the rest of our discussion and conclusion. So it's interesting to note that this trial does not just provide evidence for the effect of one single nutritional component. Say, like, you take this one thing and while you're in the hospital with cancer and you live longer. It's not that at all. It suggests the overall strategy of providing nutritional support to reach different goals for specific illnesses. Specifically, it was found that there were significant improvements in the function and quality of life outcomes, which is a major concern for cancer patients. And it's worthy to note that they say that it's important for clinicians to focus on nutritional support, especially in patients that show low appetite, rather than just focusing on the anti-cancer treatments to really get to, yes, the root of their diagnosis and problem, but also providing this nutritional support is going to be really critical for their mortality rates and just their quality of life in general. So the main conclusion of the paper was that individualized nutritional support reduces the risk of mortality among hospitalized patients with cancer at nutritional risk. The data supports the need of malnutrition screenings upon hospital admission, at least for cancer patients, and should be followed up by individualized nutritional support. So the future research that this paper had indicated was the need for additional trials to validate the findings in the population of cancer patients in the outpatient setting, since there was no outpatient, like any kind of outreach to the outpatients after they were discharged from the hospital. And this study should also be taken to different populations and clinical settings. And there's also a need to extend this study to surgical patients, as they were excluded from this trial. They didn't exactly specify why, but that's something that I'll definitely be thinking about, and you guys should too, because I think this would be especially interesting, as nutrition could be a way to improve surgical outcomes, especially for cancer patients. And that's all I have for you. Thank you so much for watching. And If you're interested in reading the article, this is my Works Cited page. This is the link right here. You can just copy and paste. Again, thanks for watching.